I would just like to say thank you to everybody who is joining us. My name is Liz Mangami. I am the director of the Advancement Office here at Waterford, Kamhlaba. And as part of the programming that we offer as the Advancement Office is a way to engage with our alumni. And this whole lockdown COVID-19 pandemic has given us a unique opportunity to be able to connect with our alumni all over the world in an easy way without having to ask our alumni to jump on a plane and come and speak to the community. So we've launched what we're calling the WK Alumni Speaker Series, and it gives us an opportunity to invite all of our alums who are involved in different areas of work and just come and have a conversation with us about what they're doing. And so that's what this series is about. And as you will hear later on, we have two of our alums from the 70s who are joining us today and will be sharing their knowledge. A huge piece of being a part of the United World Colleges is that we are a member of a huge network. And so we are sharing this platform today with our colleges across the world. And I would like to hand over for introductions to my colleague Celia from the International Office, who will ground the UWC Unlocked talks for us. Celia?
Hi everyone, yeah, so as Liz said, I'm Celia. It's nice to see some familiar faces as well from the Unlock talk. So many of you will know about the series, but yeah, similarly to with the Waterford Alumni Speaker Series, we've also had a kind of movement-wide speaker series where we have people from different colleges, different generations from all over the world who come and speak on different topics. And so this is kind of one of our first collaboration events, which is really exciting. So I'm very grateful to Waterford to share the space today. As it is a collaboration event, but Waterford are kind of the main drivers behind today's event, and they've also done all the work to get the amazing program that we've got today, which I'm very excited for. So I'm going to be playing more of a background role. But I just wanted to say that I'm here as usual. If in case anyone has any tech issues, you can always message me on the chat. And also as a reminder on that note, please do keep yourselves on mute during the discussion unless you're called upon to unmute. And yeah, I think that's all from me for today. So I'll hand over as quickly as possible to you, Liz. And I'm very excited for the rest of the program.
Thank you, Celia. As part of collaboration, we're also launching this webinar series as part of a partnership with the Waterford Kamhlaba Foundation of South Africa. And we have the chair of the foundation here today to introduce himself and the foundation, as well as our speakers. So I'll hand it over to Sandile. Thank you.
Thank you, Liz, and good evening to everybody. I'm really honored to be hosting this webinar together with UWC and Waterford Kamhlaba. I'm an alumni of Waterford and currently the chairman of Waterford Kamhlaba Foundation in South Africa. We focus on continuing to support students in the school in fundraising towards bursaries and so forth. So really honored tonight to be here participating and hosting the dialogue on health and COVID. So with that, I'd like to then hand over to Professor Whiteside, who will be moderating and chairing the conversation with Dr. Moeti on today's topic. Thank you. Over to you, Professor Whiteside.
Thank you very much. Before I hand over to Sidi, we had a long chat last night. Unfortunately, we spent more time, Sidi, talking about the fantastic time we'd had at Waterford and not perhaps as much time as we should have on what we were going to do today. But I think we got ourselves fairly well sorted out. It's a real honor and a privilege to be on this discussion today. Waterford meant so much to me. I think it did to anyone who is an alumni there. And it's nice to see familiar faces. Quinton Reisman, whom I was at school with, believe it or not. He was the intelligent one in our class. And then the various people I've worked with over the years at Waterford, Jeremy Locke, who was a governor, Stephen Lowry, of course, the head, and so many of you. CD and I were there in the 70s and 60s and 70s in my case. And I think that one of the messages I would take from that period is it was a very dark time in Southern African history. Apartheid was increasing in intensity. I don't think any of us knew what quite was going to happen, but we did know that it was unacceptable that it should be the way it was. So I think we're in a very dark time again. And I think the one message that I'd like to give to the younger people on the call is that this too shall pass. It is something that we will get through, but there's no doubt about it, for the next little while, it's going to be extremely intense. I am Alan Whiteside. I was at Waterford from 69 to 74. I then went to the University of East Anglia in Norwich, because in those days, if you went to a South African university, you ended up in the army, and I wasn't prepared to do that. And I then went to Botswana and joined the amazing Ministry of Finance and Development Planning for 2.5 years before I went to Durban, where I was in the economic research. Then I set up my own institution, the Health Economics and HIV/AIDS Research Division, which I ran. And then after 30 years in Durban, I thought to myself, and many of our leadership should remember this, the only way to have a legacy is to leave, because until you leave, it isn't a legacy. It's you doing the same thing and probably doing it worse. So I moved off to Canada and joined a university there as a chair in global health policy. I'm now on sabbatical for a year, and then I have a year before I leave the university and start looking for other things to do. One of them is going to be very much around looking at new diseases and how we need to deal with them. I won't say any more about myself, but I will say it is such a pleasure to be on the panel with the amazing CD Moeti, who was one of the two core families at Waterford. The other one was the Lebonas. There were lots of Moetis and there were lots of Lebonas. And it is a real pleasure to have her. She has risen very high in the WHO ranks, but she is still, at the end of the day, in my opinion, and it was confirmed last night, a Waterford alumni with the values and the principles that were inculcated in us at Waterford. So, Tsidi, let me hand over to you to go ahead with your introduction, introduce yourself. I'd never do it adequately. And then say what you're going to say, and then we'll I'll add and throw it open to the floor. Welcome, everyone. It's a real pleasure. Over to you, Tsidi.
Okay, thanks so much, Alan. And first, let me just say a huge thank you for having been invited to join this conversation. You know, like you, Waterford has a very special place in my heart. So I'm so happy to be back up on the hill. That hill I used to dread walking up when I used to go into town to for a break and do mischief. But I'm so very happy to feel back there with everybody. So thanks so much for giving me this opportunity. Alan and I used to sit at the same table at lunch. I used to be the prefect, and he used to be the littler boy making mischief with other people. But so we've got this bond from many lunches ago when I have to ask him to finish his food. So indeed, I'm so very pleased to be here. So to say a little bit about myself, I'm from Botswana, but I'm originally from South Africa, in fact. So just to make the link with the era, the injustice of apartheid, and the difference that was made by being in a school like Waterford. In fact, my family migrated to Botswana when I was 11 years old, and we had tried already for me to get an education outside of then apartheid South Africa. For 2 terms, I went to St. Teresa School in Manzini, and believe me, crossing the border from South Africa to go to school used to be a mega effort. My mother used to have fights with the police. My dad was the peacemaker, telling her to be calm. We just want to get across the border and drop her at school. So even from that young age, and then 2 terms later, my father was being harassed a little bit by the police, and we moved to Botswana. So I'm a migrant and grew up in another country before the word migrant became a bit toxic as it is today. But I came to Waterford to do my A-levels. So I went to high school in Botswana, in Gaborone, and then came to Waterford in 71 and 72 to do my A-levels. And they very much appreciated that diversity and that emphasis growing out of being a Black South African on justice, equity, fairness, everybody getting a fair chance, which was really inculcated in one from childhood, reinforced very much by the environment in Waterford, and has been something that's been central to my career, my development as a person, as a woman, as a professional up to today, including some of the areas in public health that I happened to work in. When I left Waterford, I went to university in London and trained as a doctor at the Royal Free, and came back to work in the public health system in Botswana from there. And I was very lucky, really, that I started off working in a district hospital, a small hospital in the southern part of Botswana, then worked in TB, and started already to have a little bit of an interest in public health. I then went in and worked in the central hospital, and I really wanted to be a pediatrician. I loved working with children, and simply because I did not choose to go and do my specialist training in South Africa, I in the end ended up making a compromise. I was married by then with a small child, and decided I can't leave my child for several years while I go and specialize in go and study public health. It takes a School of Hygiene and Tropical Medicine to study then public health with a strong emphasis on occupational health. And that was really also influenced by the mining history of South Africa, the workers' health issues. So it's a very, in a sense, by the political context in which I've been born and grown up, and the issues of justice, equity, and other people's health. Anyway, to cut a long story short, I came back. After working in Botswana in the clinical area, I came back and worked in occupational health, indeed, and got very involved in the history of mining, the story of people who'd been to the mines, working in pneumoconiosis, workers in the farms in Botswana, working in agriculture, and sort of built up this interest in health and equity, which had me ending up working in the UN. I worked in, I joined UNICEF, first of all, and worked in Nairobi. Then after that, I've worked in a couple of UN agencies, UNICEF, UNAIDS, worked very much in HIV and AIDS, which is something Alan and I have in common again, and have been fortunate to live in a number of countries in Africa, in Zimbabwe, Zambia, Malawi, Kenya, and I also worked in Switzerland, in Geneva. Worked in different areas, as I've said, very much communicable diseases, and also worked in chronic diseases for a couple of years, which was a singular lesson in inequity, because that's a very underfunded area in African countries, and we know it's a huge problem globally, everywhere, and ended up standing to be the regional director of WHO. So I work in Brazzaville in the Congo. That's where I'm based. I've lived in the Congo now for 12 years. Whenever I tell people at home I live in the Congo, I think they imagine the DRC, and everybody gasps, oh, how is that? How do you survive? And I have to tell people that I feel much safer, frankly, walking around here than I do in Joburg, and even to some extent in Gaborone. So, but occasionally there's war breaks out. So that's the difference. And I've learned a lot about the African continent from my experience, which is something that I treasure in terms of my own understanding of the world and of Africa's place in the world and of the role of WHO. So I've been very fortunate. I'm in a position now where I head an office which covers 47 countries. So there's a huge diversity in the work that we do because the countries themselves are so diverse. And I'm very pleased to join with you today to come back to that beginning of this understanding and this interest in equity and justice, because yes, you're right, Alan, we've ended up in a place, not only because of the COVID-19, which is showing that inequity can make such a huge difference as to who gets ill, or lots of people get ill, but who dies. But in terms of what's happening in the world today, generally, and the polarization politically at the global level within countries, which is a huge challenge to our collective interest in helping all people to have a fair chance to make whatever they can of themselves and have a good and dignified life. So thank you for having invited me, and I'm very excited about the conversation that we're going to have.
Then let's open it and let's talk about the issue, and let me guide us through the conversation as we discussed last night. Is that okay with you?
Yeah, that's absolutely fine with me.
So maybe the place to start would be, you talked a little bit about how your career developed. Maybe we could start off by why don't you tell us what took you into medicine?
Yes. Okay, you know, both of my parents were doctors. So when I was 15, I was absolutely never going to be a doctor. I was very determined not to study medicine. And I wanted to be a physicist. I thought this is what clever people do. This is a difficult, interesting, difficult subject that will show that I'm really bright. And then when I got to do and I quite liked physics when I was doing my O-levels. When I got to do my A-levels, I don't know quite what happened. And I used to have a friend, Leslie, and I used to spend a lot of time chatting during the physics lessons, I have to say, which was a great bother to the teacher. Maybe that's why I went off it. I ended up by default really deciding, okay, why not? I know a lot about medicine. I listen to two people talking about health and medicine all the time at home. So okay, that's what decided me to go into medical school, really. Mm-hmm. And in a way, it was also having seen my parents work in a private practice in Guatemala, in Springs initially, which was really a kind of public service with a very low income communities going out at night to do calls in the way that you would in a township in those days when there was a very limited access to healthcare for people. And then working in public health in Botswana. My dad was involved in the smallpox eradication. So as a certain part of me was connecting already to sort of public health for everybody. And as you know, Botswana is an environment at that time was a very low income country, but which went into primary healthcare, health for all very, very early. So it was picking up on some of those values that I had absorbed as a child from the context in which I grew up.
Mm-hmm. So, and then of course you have joined WHO, and you now, and because becoming the regional director is partly a political thing, because you have to stand for the position and be elected to it. Tell us, the people on the call, a little bit about WHO and why you believe in it and you believe in its mission, particularly because we currently have the US wanting to withdraw from it. So tell us about the WHO. What makes it special, and your involvement in it is something that motivates you.
Yeah. I believe in the United Nations, first of all, and WHO is a UN agency. So I believe in this platform that brings everybody in the world together, that has member states which are very different, agreeing together what's going to be for the common good in all sorts of ways, starting with development. So the sustainable development goals, something to which everybody can aspire, we can all work towards collectively across the world. And WHO is the health agency that has the mission to ensure that all people can attain a good state of health in a way that is equitable, that is just, that gives everybody the opportunity to make the best of their potential. It's also its mission very much to put all the efforts and resources together. So one of WHO's main roles is to gather knowledge about health and turn that into a public good, turn that into something that all governments and all people can have access to work on improving health. And it is also, in theory at least, a mechanism within within which all countries are equal. I mean, in actual fact, it turns out that not really, but still, the principle is there that you come together as a world, you work together towards a common good, you share your knowledge, you share your resources for the interest of everyone, and we work on making sure that everyone gets a fair chance at being in good health, and we work very much on preventing health problems in addition to ensuring that people have access to essential care. We look into research, finding out new knowledge about health and sharing with everybody in the world. So it's going back to those principles of common effort for the good of everybody. As I said, I think the current context is challenging that very, very strongly in the tensions around the world, the polarization at the global level politically, and we need to continue to promote these principles and to turn those principles into concrete action so that, you know, the last child of a low-income family in the furthest village from the capital city has a fair shot at being healthy, at developing and finding ways to improve their lives. This is what I believe in WHO for.
So let's talk. I'm not going to put you in a difficult position by talking about the situation with the US, but with their threat, which I fear will be carried out to pull out of the WHO. But let's talk about what you would want other governments to be doing at this moment. What's the best way they can support the WHO at this moment in time?
Yes. First of all, I think what other governments can do and what they are doing is to reaffirm their confidence in WHO and their interest in having WHO continue to play its role at the global level with the engagement of all member states. And this we appreciate very much, and this is what has been happening. Secondly, to be fair, we are also very clear that other member states have to ask us as a secretariat, as WHO, to evaluate our work, so to be accountable for our work, to demonstrate what it is that we are doing, and if we have challenges, to be frank about the challenges that we are facing. Then I'd like to emphasize, you know, WHO is an organization that is very much composed of member states and a secretariat. So virtually everything that happens in WHO is the result of the collective action of member states and the secretariat. So I would like them as well to demonstrate that balance between the responsibility of member states for what happens, including this response to COVID-19 and the response to various crises in the world, and the responsibility of a frankly relatively underfunded secretariat based on the mandate of WHO, which is very broad for health, in the context in which many players are now getting involved in health, which is good. It means that health is going up in the political and economic agenda of countries and of various entities, including the private sector. So we want in WHO to work with all our member states. And when I say member states, not only the governments, but the people, the institutions. And we have with very important institutions in the US and other countries, very good collaboration relationships that go back over decades. And our wish would be for that partnership to continue.
Good, thank you very much indeed. I would say to people on the call, please feel free to use the chat if you want to raise questions, which we will try and come to and take as many as possible. But we're going to carry on with this conversation for a little bit longer and then move to the chat. And we are aware that Sidi will have to leave, but we will have her colleague Michael Yao on the call to try and answer some of the additional questions. Sidi, before we get to COVID, which is, let's face it, is the dominant thing on everybody's minds at the moment, what health challenges should we not lose sight of?
Okay. Yes, I mean, first of all, you know, the health challenges facing different people across the world are so diverse. They're so different. And I would say that one of the first things that we must not lose sight of in wishing to have everybody healthy is the issue of equity. You probably heard about the debates that have been going on about universal health coverage, as it is called, in different ways in different countries. Just that idea that people have the right to have access to healthcare without being driven into poverty. So it's important to have the kind of mechanisms for financing health that are fair for everyone in the world. So whatever your problem is, whether you have HIV because you are in a Southern African country with a high prevalence, or whether you have chronic diseases, cancers, hypertension, cardiovascular diseases, because you are in a different context, you have the right to have access to healthcare to prevent illness if it is possible. And that means that you need to be in an environment where the legislation is in place, the drivers of ill health, including the actions of the private sector in marketing certain unhealthy goods, are managed in such a way that they don't constitute health risks. And you've seen the debate across the world. There's a debate very much in the US, in European countries, including in the UK, where I trained, about what is fair in terms of financing access to health for people. And it's a very hot topic in African countries, which are having to struggle to put in place those pre-financing health insurance mechanism that close the gaps and ensure, as I said, that people living in peri-urban areas in poverty are able to have access to decent healthcare without impoverishing themselves. Because for many African families, all it needs is for somebody to fall ill before people have to start going into debt. And we know that those inequities are everywhere. And then secondly, I think that we need to really be attending to environmental issues, the impact on health of climate change, the impact of the environment, and the fact that in order for people to be healthy, you don't just need hospitals, you need the proper, if you like, policies of different sectors. What do we do to develop different sectors that might have a negative impact of health, and how we guard against that? I think that's extremely important in today's world, because everything is interconnected. And then thirdly, just looking at the link between some of the determinants of health, poverty, gender, those drivers of inequality are extremely important for us to pay attention to in real ways. You know, when I was in the London School of Hygiene all those years ago, I wrote an essay, I remember, on women's work, which is undervalued and underpaid. And it's a very painful reality when you look and see that those differentials in earnings between men and women have been sustained over the decades. We're still arguing about them and still trying to find ways to bridge them. And so again, it really very much comes back to having a world which is fair and just as a principle and in practice, and finding ways in different sectors to work around that in the interest of health. I think. And then on the other side, I think we've got huge opportunities with some of the technology that's available to help countries to jump over some of their gaps if we invest wisely and we use in fair ways, and if those technologies are made affordable to different countries and societies, including to poor people, so that a technologically advancing world is not leaving them even further behind, even as far as health is concerned. So those are some of the things I think are important.
Yes, just let me chip in here. With COVID at the moment, my doctor's surgery in England is closed. They're not seeing patients, but you can phone. You can use your webcam, if you have one, to have a consultation with your doctor. You can get prescriptions on the phone, but the one thing you can't see is actually go into the surgery. You have to go to the accident and emergency if you actually want to see a doctor, which is a very interesting reaction. And I'm wondering how that is going to leave healthcare in England in the months and years ahead, particularly since I have a relatively good technical ability, and when I can't achieve that, I have a son who has an excellent technical ability and will come and help me in my office when I need him. So thank you, Douglas. You make these things happen. So I do think that there are changes happening in regards to the technology, but the problem is that not everybody's going to be up on it. In fact, you know, when I look at the older people in the society, I wonder how they're going to achieve the technological gains. I don't think the poor people in Africa will have as much problem because smartphones are so much as a system there. So do you think there is a gap, a technological apartheid?
I think that is a risk. I mean, I have to say, being technologically quite mediocre myself, I have to admit, as my daughter keeps telling me. So I've got a daughter in her early 30s who is a journalist, who is dismayed occasionally when we're together. I try my best. I'm already in that age group, Alan, since I'm 2 years older than you or whatever. But so we have to find ways to make sure that for the essentials that they need this for, that older people continue to be engaged with technology as the world is changing. But I mean, I think that for poor people, for example, in Africa, we're using very much, and we're promoting and supporting governments to use technology in all sorts of ways for surveillance, for being in touch with people. It's a challenge in terms of the access and the affordability for many people in the region. So this has to change so that you cover both people living in the low income environments in the world and then people who are older. And we absolutely don't want an apartheid caused by technology, not only in terms of ability to use, but also in the changing landscape of employment and the kind of jobs and work that people can have as more and more functions are replaced by technology. So we need to be looking, including in the health sector, we need to be looking at educating and training people to adapt, to adjust, and to find ways to continue to be relevant, as we want people to continue to have livelihoods in the days of artificial intelligence and the type of technologies that can take over many roles that people are playing. So I'm sure we know that even in some of the very tense political discussions that are taking place, that replacement of people by technology is one of the issues, one of the challenges, even in Western countries.
Mm-hmm. All right, well, we probably ought to turn to well, I consider this to be the burning challenge of the day, which is the COVID-19 epidemic. Would you agree with my assessment that this is the burning challenge of the day?
No, yeah, absolutely. It is absolutely the burning challenge of the day. And I think that I mean, one of the surprising aspects of COVID-19 to somebody like myself, who is used to thinking about low-income countries, is the degree to which better off countries and societies were so unprepared for COVID-19, despite all the discussion in the last decade about preparing for a pandemic. I mean, if you look in certain circles, people have been talking about this for a number of years. And when we had the West African Ebola outbreak, I mean, we've had a series of outbreaks that have been very threatening. When we had SARS, when we had H1N1, there was a lot of discussion at the political level, at the global level, that we must prepare for a pandemic. We must really get ready. So here we are, and we've had demonstration that actually we must prepare for a pandemic absolutely everywhere in the world and test out our preparedness and not just assume, because we spend a lot on health and we spent a lot on curative services mainly and prevention of the most obvious diseases that are confronting us every day, we're ready. It's turned out that the world has been spectacularly unready. And one of my own fervent hopes is that, unlike in the past, every time we've come out of the threat of a major epidemic and escaped, and then countries have not invested in what's needed, both to provide, if you like, equitable access to good quality healthcare, because it's very much linked then with having a resilient health systems, which is able to detect an outbreak early, is able to contain that outbreak early, and is able to prevent it going into a big epidemic. In the African region, after the West Africa Ebola outbreak, we carried out in all our countries virtually an evaluation of their capacities to deal with outbreaks. So we've got nice plans sitting somewhere, and the investment in them, both domestically by the governments and internationally by the international community that was pushing for this, has been virtually non-existent. So it was sitting ducks for COVID to arrive, and here it is today. And my sincere hope is that this is going to be different, as you were saying, because the impact has been so incredible, or will be incredible. It has been incredible already. So that's unprecedented in the modern age experience.
This is a copy of a publication called Preparing for Infectious Disease in Africa. It's one of many. This one is actually written by one of our mutual friends, David Sawada and colleagues. And it was prepared for the British government. Why doesn't anybody listen to us when we warn them about diseases? You will remember how I was shouting about AIDS back in 1990, saying this is going to be a real problem. What is it about people that they don't listen when we say warn about diseases?
I'm not sure I can answer that question, in a very coherent way. It just remains one of my own frustrations. I think that, well, if I speak from the perspective of African countries that with the limitations of their financial resources are always juggling competing priorities and trying to decide. What I observe is that investments are very much in matters of the moment. So we build hospitals because people need care now. Sometimes we build hospitals because we need to demonstrate to people quickly that we care about you, and here's a big hospital with the latest platform of care, with the latest equipment and some specialists to treat those people who can reach that kind of hospital, which is not everybody who needs access to healthcare. So those basic ideas of investing over years at the community level, at the first level of care, to make sure that then you reduce the number of people who need the big hospitals. And even more challengingly, of investing happening. That's proven to be an intractable challenge in many settings. So we've seen billions being spent in an outbreak when it actually happens. So the Ebola outbreaks, for example, the one that's just ending in the Democratic Republic of the Congo now. So when that happens, there's an outpouring of response money. It's also, now speaking from a region which is highly dependent on international support, that sometimes the financing of health is very fragmented around different diseases, around developing health systems which are very poorly funded, which is something that is unfortunate because they are the basis of solving all the problems, including for outbreaks. And then preparedness for outbreaks is just somehow not appealing until such a time as an epidemic happens, then we pour in lots of money. It is extremely inefficient. So how to prove, and quite often when I've spoken to people in some donor agencies about, if you supported this government in a more, if you like, systemic way to improve the system for everyone, apparently it's very difficult to show that that investment shows results, produces results. So it's easier to say we had money for HIV, we bought antiretrovirals, we organized a separate procurement system, it was able to deliver, and we've treated X number of people. Here's the proof to whoever has to approve your budget for the next time. But to show that, I invested in healthcare workers, in a procurement system, in a data system, and in primary healthcare, and these are the health improvements that have taken place, apparently is more difficult. So we need to find ways to demonstrate this, and even demonstrate to the Minister of Finance of the African countries that, if you invest like this over the years, it won't be dramatic, but it will be sustainable because you'll be doing it within the framework of your own budget. So we need to be smarter about making the case, apparently. We spend a lot of time now thinking about investment cases. We need to find one that will hit the spot as far as this is concerned, and perhaps this experience finally will be one.
All right, let's turn to COVID. Folks, I'm now going to move us on to COVID, and we'll carry on with your colleague Michael Yao when you have to dash, because I am aware you have a hard stop. So, Sidi, when we look at the world map, and I use the John Hopkins website, 13,382 cases, 3 million in the USA, near 3.5 million, 2 million in Brazil. India comes next with just under 1 million. Russia, 750,000. Then we come down to Peru. And the first African country that has a significant COVID epidemic is South Africa, with close to 300,000. If we go to where you grew up, Botswana, 399 cases they're reporting. If you go to Eswatini, there are 1,500 cases. What's going on? Why is Africa seemingly spared?
Okay. Well, South Africa is part of Africa, so Africa is not spared. And first of all, I think Africa is less connected by international travel than other regions. And then we've looked at data from ICAO on this. So what's the rate of international flights per population in those countries? So Africa is less connected. So that level of risk was reduced to a certain extent. And then secondly, we've seen that the virus entered the African region, basically reflecting the strong links between Europe and Africa. You know, there was a panic about China because African countries are also strongly connected to China. But the Chinese basically tested and quarantined anybody who was traveling out quite early. So that didn't happen. And then by the time the very difficult situation was happening in Europe is when then we got travelers, both Europeans for different reasons, and the many Africans who live in Europe coming home, and the virus came into Africa that way. So is it because of a young population? That might be a factor, because now there's indication that people below the age of 20 years are less liable to be infected, though they do get infected, but not to the same degree as older people. Is it temperature? We think not. And at the moment, we have seen the virus in most African countries concentrated in capital cities, although there's been geographic spread in a number of countries. So it's very much in Africa centralized in capital cities, though it's spread to some extent in some countries. I think the lockdowns made a huge difference. The lockdowns were imposed early and quite comprehensively in a number of countries. And people just having to sit, not be able to move, did make a difference. It bought some time. My concern now, when I say that Africa has not been spared, is that the lockdowns had a profound and immediate economic impact at the household level, at the national level, and this impact is going to continue over a few years. So it's been at a huge cost that we've managed to slow down continent-wide the spread of the virus. That cost has become unbearable. So most countries are opening up now, their economies, people are able to move around, the lockdowns are being eased. And I'm very worried that we're going to start to see an uptick. This is what's happened in South Africa. There was an early lockdown, which did slow down and bend the curve somewhat. And then there's been a push to open up, and we are seeing now the exponential increase in some hotspots in South Africa of the virus. And there's this juggling and attempt to balance between the hardship suffered by the huge proportion of low-income people in Africa, the economies themselves, and the need to contain the virus. So the public health measures that are needed to be able to test people, find a case, find the contacts, isolate them, have been expanded to some degree. I believe we need to continue to work very hard with governments to expand them even further so that we try and get ahead of the virus, especially into rural areas, prevent the geographic spread. I think it's very much a work in progress, and I'm concerned that we are now in a very challenging phase. South Africa is just leading, and the extent of what's happening in South Africa is way beyond what's happening in any other country in the region. And that also is driven by the disparities and the inequities and the structure of the South African economy, which is comparable to what is happening in other countries, in the UK, for example, in the US. Yeah, so it comes back to that very often.
We are running out of time, I'm aware, and I need to ask you more questions. We've got a lot coming in on the chat. So you wrote in the Daily Maverick that classrooms, I understand, classrooms should be reopened, that kids should go back to school. This is very much my sense of where we should be, that we shouldn't be working against the education of children. We shouldn't be discriminating against children, particularly in the UK, particularly since so many people rely on free school meals. Would you urge people to go send their kids back to school and ministries of education to reopen the school systems?
I think that's a very tough one, and it needs to be taken on a country by country basis. I mean, I think it's very problematic to open schools when the risk is still significant and when the resources are not there to ensure that this is done in a safe way. And again, we've started to see in some of the countries that we are aware where the school system has the money to ensure the spacing of the children, the PPE for everybody has a mask, it's possible to restart school, or where there's a kind of mix, a blending of coming to class but not every day, some remote learning is possible. There are contexts where it's going to be extremely difficult to do that, even to have water and soap for hand washing regularly by the children in school, for cleaning of surfaces to make sure that the sanitizing happens and it's safe. So what I would say is that this needs to be done on a case-by-case basis with a very robust analysis of the risk. And as is happening, to be very flexible about the fact that it might not be possible to have all the schools open everywhere, and to recognize that it needs an investment. It needs some funding to make sure that it's possible to have different sessions. You have to stretch them out. So who's going to be teaching those children in different sequences throughout the day? I think it should be very data-driven with a strong emphasis on safety. Because even if the children themselves don't get severely ill, they go back home and they may endanger other people in the family.
Okay, what about other health issues, immunization programs, which are being hit by this, people not going to health systems? What impact is COVID having on the other essential health services in Africa? I can tell you it is having one in the United Kingdom. You don't have to wait in accident and emergency for very long now. But in the rest of Africa, what's happening?
Yeah. Oh no, I mean, there have been immediate drops in access to all sorts of services in the African region, immunization for one, and it's showing we have outbreaks of measles in a number of countries. So people don't have access even to antiretroviral therapy in some countries. So people with HIV and AIDS are getting behind with their access to treatment. Family planning services have dropped drastically in some countries because of the safety issues. People are afraid to go, and it's not possible to provide those safely and in a way because of the PPE shortages in the region. So there's work being done to help countries. It's a very similar issue to schools being opened. It's imperative that these services continue, but that they do so in a way that is safe. That's not going to put people at risk for the transmission of COVID-19. And we're working with countries to try to organize that, how to do perhaps more outreach services. So if you're going to vaccinate children, don't collect them waiting in a queue in a clinic to be vaccinated there, to phase in the service delivery. Again, meaning you will need to invest in the staff time to do it more broadly. You will need to find additional space to do it. You'll need more logistics, transport for outreach services for the health workers to go out and provide these services. But this is essential to be done, and we're working with countries. They're starting to pick up on doing this in a way that's going to be safe. It's important. I see one question being asked, if I can just make a comment on that. How sure are we of the current incidents because of the level of testing by Quinton Reisman? That's a very frequently asked question, which which is a concern for us as well. I mean, we ironically, just as the virus was landing in Africa, then the global market for test kits just got absolutely distorted. And those countries that have the money to buy up the supply and the people who are speculating bought up the supply, it was extremely difficult for African countries to have access. So at the beginning, so in about March, after having done a good job of testing out alerts, it became extremely difficult for countries to have access to these supplies. We've been able, working with the African Union and provide some supplies. Not that the lockdowns helped at all with transporting these supplies. So there's been an increase in the level of, in the per capita testing, even in the low income countries that depend very much on international support. There's no doubt that there's a certain degree of underestimating the numbers of cases in some of the countries. I wouldn't say that's the case in South Africa, for example, which managed to get access to these commodities and has gone out on a very aggressive testing campaign. But other countries have struggled. However, I don't think that we have thousands of African people dying of COVID-19 undetected in the countries. No, I don't think so. So I think there's a certain degree of underestimation, and there's a lot of work being done to try to find whatever supplies to scale up the testing. And what we've learned is that you have to do this in several ways. First, you have to very much target those who are most likely to be ill when your supplies are short, and the earlier the better. So people need to know if they've been a contact, go for testing. If you are starting to have the mildest of symptoms, don't wait until you need to be hospitalized, go for testing. And then also use a combination of test kits to go and do surveys and to see if people have antibodies in certain geographic areas which can tell you that the virus is here. And then you can invest your precious resources to look in a more focused way. That it is one of the challenges in the situation. And we keep praying for global solidarity, for a fairer way of the markets to work. And I guess that's one of the challenges of today in general. So
I'm very aware of your time constraints, Sidi. So let's ask you one last question. This is a unique opportunity. You're now connected with the Waterford alumni and friends of Waterford and people who know Waterford, et cetera, et cetera. What's the one thing you would say to everyone who's on this call looking into the future? What have you learnt, and what would you like to see them do?
And you acknowledged it from the get-go, you acknowledged it last night, are people of a relatively privileged background, I think. We can acknowledge some more than others. But I mean, in most African who is struggling with life. And that's a privilege. And what I would advise, even if the world is very different today than when you and I were at Waterford, and in some ways life has got tougher for people, is carry in your actions, if you like, that sense of solidarity, fairness that was inculcated, that was such a central part of the philosophy and actions at Waterford. And even as you strive for yourself, look out for others, mentor younger people, be a voice for justice and equity in the world, as well as in your own actions, do that. Well, of course, you look out for yourselves, because I think we do need, today more than ever, that critical mass of people who care about others, who care about fairness, who will push back at the polarization and the inclination to care for self, whether it's at the national level, the government level, the level of politicians, because in the end, it's for the good of all of us. And I believe in that very strongly in my work in health and in life in general. Thank you.
All right, I think you have now given us 3 more minutes than we expected, and I think you need to go. So parting thoughts, and let's say goodbye to you, and then we'll carry on with Michael going forward.
Okay, thank you very much. Thanks so much for having invited me. Thanks, Alan. Bye.
Okay, cheers. All right, so thank you, Tsidi, and let's give you a round of applause virtually. Good. Michael, you're in the hot seat now. Let's carry on, and now what I'm going to do now is I'm going to go to the questions which have been appearing down the side. The reason is because we knew that Tsidi had to leave at 10:06. So, Michael, is there a way for people who are listening to this call to provide input into the activities and the thoughts of WHO generally and WHO Afro particularly?
I may say that the way of contributing is rather at the country level. And it's a process that in Africa is also well known, even responding to other outbreaks like cholera or Ebola, like having also a community dialogue involving different community leaders, including the youth and even the students. So the challenge being how can we then collect this input coming from countries and take them into account while planning. Our countries are so different that this dialogue, I think, has a better add value doing it at country level and taking it into account. We are advising countries to have actually scientists that can advise, and some of our sister agencies like UNICEF are doing this kind of interaction with people to collect what is the thinking, what they think about the disease, about the responders, and how this can be readjusted. And actually, we learned a lot from the Ebola crisis in DRC, where we had the huge community resistance and that were appealing us to open more, to listen more to the people that we are serving.
So I guess the message there is there's always civil society that you can engage with in your countries wherever you are, and that is something which I would strongly recommend. Okay, carrying on, looking at the questions on the side here. Why is the death rate so much lower in Africa than in the rest of the world, do you think, Michael?
There are a few hypotheses. The first one is the demographic. We have a younger population in Africa, and it seems to have also from information or data that we have now, most of the people that have a severe disease are those who have some comorbidity related to diabetes or cardiovascular disease. And this number is lower compared to others. So this can be one of the justification. The other part could be also in the fact that maybe there are some factors related to people living in Africa, but these need to be, I think, studied further with many research. And unfortunately, it's an area where we have some weakness in Africa. We are trying to catch up, trying even to mobilize funding for people to learn more, to understand more what is happening. And of course, we have less cases, and most of the cases are appearing in the capital city. Our fear at the beginning, if we have a wide community transmission and we have many remote places that have to have severe cases, the mortality could be very high. But time being, the disease still in urban areas in most of the country. So these are a few hypotheses that we have to explain the low number of mortality, the demographic, the fact that it's occurring in places that can manage. We don't have yet a huge number. And if we see the mortality trend is increasing now, that the number is also increasing in some of the countries. If we take the example of South Africa, is what is appearing. So low cases appearing in a system that can still cope with turn out having also low mortality.
Thank you. What do you say in I mean, if we take Swaziland or Eswatini or take Kenya, how do you respond if you're living in a slum where you don't have running water and the idea of isolating yourself is just a pipe dream? What would you recommend to people in that situation?
This is one of the main challenges in African city, and we face it even in other outbreaks. I was mentioning cholera that is usually affect this setting. The idea is this kind of settings need specific approach and support. We advocate to involve more NGOs. So one of the critical interventions, if we look at they spread in some of the Southern African countries, is to make sure that some NGOs at least can fix the issue of providing water and providing also what we call in the humanitarian jargon, non-food item, that you cannot even just give the water and ensure that people will wash their hands if they don't have soap. We had cholera some years ago in Zimbabwe, and one of our critical interventions was what we call community-based package, where you have water purification tablets, as well as also soap and even bucket to make sure that people can collect water. So in these settings, without these interventions, the population remain very vulnerable. You cannot also, some of the physical distancing are hardly applied there because it's not, as I was saying that some of the physical distancing recommendations are hardly also applied there. So in this case is to ensure that you have a mechanism to have a community-based surveillance, at least so that you can pick people that get sick, that need urgent attention. You can also give priority to community-based treatment, and this you need also some of the NGO partners. So these are partners that are critical in our African context that we need to collaborate with and to ensure that this critical gap are filled. If not, these people remain vulnerable, and we can face even a huge number there, and also a challenge to control the outbreak.
All right, let's bring this conversation back to the place we know and love, Waterford, Kamhlaba. And I don't want to surprise anybody with the question. So Mark Mills and Stephen Lowry, and possibly even Lawrence Nodder and Donnie, be aware that any one of you can answer this. What does this COVID outbreak mean for Waterford, Kamhlaba, for the United World Colleges generally? How do you think it should influence us? Mark, if you're online and you can unmute, you can start, and then I'll move to Stephen and ask him to contribute, and then to Lawrence. So Mark, are you there? Mark is playing.
Hi, Alan.
Hi.
I am here, thank you. Alan, I think, you know, Waterford has responded in a typical UWC way. And I think particular, as I think has happened across the world, the teachers and the students have risen to the occasion. And I think one of the things to note, and I mean, this is, again, a worldwide phenomena, is everybody thinks, you know, you were talking about technology earlier on. And I was saying that, you know, we had a lot of people are very anxious coming to seek medical help. So we thought, well, we will, we developed a fantastic telemedicine program, and we've had very little uptake. And it's a bit like that with teaching, is that everyone thought that online learning was going to be relatively easy. You know, you just transition from a face-to-face teaching to an online system. And what we've discovered is that it's very difficult. But amazingly, the teachers of Waterford and the whole of UWC actually, and the students have risen to the occasion, and they are adapting. Again, we are very lucky because a lot of people have the finances, I suppose, to be able to connect in that way. But again, as I say, in a very Waterford way, the school has done an amazing job of supporting people. And I mean, for example, there's one student in the rural areas of Zimbabwe who struggles and is basically doing school on her cell phone. So she attends lessons on her cell phone, and the school has helped her by giving her data, constantly supporting her, but she's never given up. She's constant. She knows that her education and the experience she's having at Waterford is paramount, and she's staying in there, and against all adversity, she is in there. So yeah, so you know, times are different, but I think that the school's coping very well, and we really have to thank the teachers and the students for their commitment.
And I guess that's you, Stephen. So tell me, what is this meaning for you guys in the administration? And then I'm just going to give Lawrence a chance to say a few words. But Stephen, I'd really love to hear from you.
Thanks, Alan, and thanks to everybody who's contributed to this evening, and thanks in particular to Tidi. And just hearing her as an alum coming out of the fires of the 1960s and 1970s and the kind of colonial circumstances that she got an education through, it's pretty much the theme for me, which is very important, that Waterford is still doing. And even through this crisis, and most particularly through this crisis, is that we are keeping the teaching and learning going. So a lot of our students are coming to us with huge aspirations in terms of their future, in terms of their educational future. Their families and their communities are often reliant on their students successfully completing their education here. And we understand that implicitly. So for us, it's very, very important that despite the difficulties Mark speaks about in terms of the OTL and the difficulties around managing adolescents in a non-contact kind of way through their education, it's crucial what we are still doing. So our commitment has been to our parents and to our students that we will get you through your years of study as you expected to, and we will get you back here as soon as we can to continue that experience. And we will try and continue to carry on your experience. As we speak, the SRC is having public questioning events as their candidates go through the school, seeking election to the presidency of the SRC at the moment. And that's lovely to see that the kids have been able to organize that online and are looking for ways in which they can still keep the various elements of the college going in terms of our kind of UWC identity. So that's been very important. So we've tried to be as reassuring as possible to be as much as possible business as usual. One of our biggest challenges is that our graduates from last year are now going to struggle to get into US schools now. And as many of you will know, a huge proportion of our kids are taking advantage of the Shelby Davis Scholarship Program. And their struggle is going to be to get into the States for the start of the academic year in September now. A lot of them are quite disappointed and watching with bated breath as to what's going on in regard to trying to get into the States, not just in terms of the visa restrictions and challenges that come out of the current administration there, but also the travel restrictions and so on and so forth.
Yes, I think we tend to forget that. This is so disruptive. Lawrence, are you online? Because I'd like to get a final word from you.
Well, maybe it's not the final. I see lots of Waterford friends from my time at Waterford online, and Anna Marston, I think, is in a very interesting position, running a United World College now in Tanzania, and that perspective might be an interesting one. For those who don't know, I currently run the United World College in Germany, and we had space, although in a regulatory way, to keep the boarding school together, even as schools were closed down. And so we worked from the luxury position of having everybody on site. Surely we had to create quite a careful cordon around the school, so to speak. But it meant that even if classes were online, the teachers were here. And we couldn't teach in a classroom, but we could run tutorial groups. And so the teaching and learning at the school, particularly for the first years, was not particularly disrupted. Our bigger challenge, and I think it's going to be a huge challenge for United World Colleges, I think at a naive level, we think that there is something to be gained by bringing people together from different backgrounds and different national backgrounds, and and from Asia and from Europe and from Africa and from the Americas together. And certainly in the short term, I don't know how this will continue to work. And currently our situation in Germany is that more than half of our first years come from countries that Germany hasn't put on its favored list of countries where people can travel into Germany from. And so we have the danger of becoming a very European United World College, and that would be enormously limiting of the perspective. There would be something richer than simply a local school maybe, but it would be less than the breadth of perspective that normally people can gather and gain from within a United World College. So that is an aspect that I'm quite worried about, also for Waterford, in terms of people being allowed to travel from different parts of the world through South Africa and into Eswatini, and B, to what extent there will be global appetite for that.
Thank you, Lawrence. And a word from Tanzania. What's unique? What's perspectives from you?
Sure. Thank you, Alan. So Tanzania's approach to COVID-19 has been a little different from other places in the world. We've been declared COVID-free by the government here, and there's been a lot of discussion about how we're not allowed to talk about statistics in Tanzania. So we're not allowed to. There's no government comment on what the statistics might be. It was the 29th of April were the last time that there were any statistics around coronavirus coming out of Tanzania. So last week, about 10 days ago now, or 2 weeks ago probably, schools reopened in Tanzania. So all schools are currently open in Tanzania and everyone's back at school. We're, for those that don't know, we're the newest UWC in the 18th UWC, and we're on a break. But we are looking to open again in August. So we have, like Lawrence has a lot of interest from Europe. We have a lot of interest from students on the continent, and they're very keen to get back to us. We're grappling like everyone else. How can we make this as safe a kind of for students coming in? As Mark Mills said, we're seeing the same things. We have good links with hospitals here in Tanzania. We're not seeing, the hospitals are not overrun with people right now. They're not, there's the thought that they're not coming to hospitals. So for sure people will be sick, but they're not bringing themselves to hospitals. So the hospitals are kind of coping with what's going on, but we are a little bit blind on a kind of statistical level. So we are planning on opening. We planning on doing things that people are doing all over the world. Lots of washing of hands, lots of spacing, lots of trying to limit movement within the school, lots of thinking about how we can bring groups of students in and have them stay together for a bit before we put them all into a classroom. But sometimes we sit and wonder if the world will look to Magufuli, our president, and think that he somehow got it right on the continent, even though whilst at the moment there's a lot of discussion about how it's not right. We've had no sense of lockdowns here at all. If you came to Tanzania today, you would find 100% business as usual.
I write a weekly blog on COVID, and you can find it very easily if you search my name. What I wrote this week, and it was published this morning, was all this is extremely sobering. It was talking about how incomes have declined, food security is dreadful, etc., etc. And as I said, it's all, as might be expected, extremely sobering. It brings me back to the question, what can I, my family and friends, and you do? And there are some obvious answers. Spend and give in a targeted manner. So spend locally. You don't need to buy stuff from away from your local. If you can buy local, buy local. Give in a targeted manner, because more than now, those resources are needed. Put pressure on politicians locally and nationally, and be prepared to pay more taxes if you fall into those brackets, because taxes will have to go up. Think local, act global, and be kinder. Over to you, Liz.
Thank you so much, Alan. This is actually a great segue, because I would not be doing my job if I didn't say the following. Waterford Kamhlaba does a lot to help students who cannot necessarily afford to come and have a Waterford education. And part of the reason for having this collaboration today with the Waterford Kamhlaba Foundation of South Africa is that we want to raise awareness to the fact that we are always trying to support our students in various ways, and fundraising is another way that we do that. So please reach out to me and my team in terms of finding out how you can give and support some of these efforts, and for us to tell you a little bit more about our fundraising programs here at Waterford Kamhlaba. I'd like to thank everybody for participating in this talk this evening. Thank you to TD for her amazing talk and all the information that she gave us. And I'd also like to thank all the Kamhlaba community for taking time to spend time with us today, and everybody from the movement, the UWC across the globe. Thank you very much. And I'll also take this opportunity to say hello to my new boss, Patricia Angoy, who is going to be replacing Stephen Lowry next year, has joined us this evening, and it's great to have her with us. And also just to be able to boast that once again, Waterford Kamhlaba is a first, because Patricia becomes the first person of color and woman to head the institution. And we're very excited to have her join us, and hoping that COVID will allow her to be with us physically very soon. So with all of that said, thank you again to my colleagues from the UWC International Office for making this a part of the UWC Unlocked Talks, and for my friends who have joined us who are not a part of Kamhlaba but have also been a part of this conversation. This has been an absolutely wonderful event, and also special thanks to my team who have pulled this off. With all the challenges that we have. We hope to continue to see your faces for the WK Alumni Speaker Series. There will be more collaboration with the foundation, so please do look out with you in your emails. And if you are not on our mailing list, do get in touch and we'll make sure that you get that, you get signed up for all of those. Thank you so much, everybody. We won't disconnect the call immediately, just to allow everybody to give some comments or email addresses in the chat. But again, thank you, everybody. This has been absolutely amazing.
Thank you.
Bye.
Bye.
Bye-bye.
Bye.